Hello! In this talk we are going to look at some very basic settings for the ventilator. This talk is aimed at anyone who feels a bit intimidated when they look at a ventilator. There are lots of different types of ventilators depending where you work. You may come across something like this. This is a very basic ventilator that allows you to set the breathing rate, the minute volume and the peak airway pressure. This would be something that you would see in a casualty or an A&E unit or in the pre-hospital setting. Or you may have seen something like this. Now, this is a more advanced ventilator that you may see in an intensive care unit. Or if you work in anesthetics, then probably will have seen something like this. A ventilator incorporated into an anesthetic care station. They look very different, but they all actually do pretty much the same things. Now, there are 5 things we need to consider when we are going to set a ventilator. The breathing rate, the tidal volume, the airway pressures, the mode of ventilation, and then a few special or extra things to think of. As we've said already, your more basic ventilator will probably only allow you to do 3 settings: the rate, the volume, and the pressure. When setting the rate, we need to consider what the normal respiratory rate for the patient would be, and also what the end tidal partial pressure or carbon dioxide level is that we want to target. Now for adults, the normal respiratory rate is anything between 10 to 20 per minute. I would suggest that you start off with a rate setting of about 12 to 15, and then you see how your patient does, and if you can measure the end tidal CO2, you see how it responds to your respiratory rate. If you want the end tidal CO2 to decrease, then increase your respiratory rate, and if you wanted to increase the CO2, then decrease your respiratory rate. As you can see in this example, I have the rate set at 10, there we go, and the end tidal CO2 is 39, and the ventilator tells me that the actual delivered respiratory rate is 10 as well, because this patient is paralyzed and not taking any breaths on his or her own. It's all coming from the vent. Now remember, the normal partial pressure of CO2 in arterial blood is 35 to 45, or in kPa it's 4.6 to 6.0, right? Now the end tidal CO2 measurement is usually 2 to 5 millimeters mercury lower than the partial pressure of CO2, right? So let's just look at that. So the normal end tidal is actually lower than the partial pressure of carbon dioxide. And this is due to the mixing of alveolar gas that contains CO2 that's come back from the body, and mixing of that with gas exhaled from the anatomical dead space where ventilation did not occur. So it does not contain any CO2. So that dilutes the amount of CO2 that is coming from the alveolar gas. Okay. In terms of tidal volume, we are going to aim for 6 to 8 milliliters per kilogram. But now note that this kilogram is the ideal or the predicted body weight, not the patient's actual weight. So that means that you don't overventilate an obese patient, for example. So if you think about it, if you gain weight, you don't also gain lung tissue, you're just gaining weight. Your lungs stay the same size. So you don't want to ventilate at double the lung size for somebody who's double their expected weight, because then you're going to give them barotrauma. Now, there is a formula for ideal or predicted body weight, and I'm not sure if I, on principle, agree with it, but the formula is 50 or 45 for women plus 0.91 times the height of the patient minus 152.4, okay? And this is obviously in centimeters and in kilograms. The answer will be in kilograms. So that would mean for a 175 centimeter tall male, we would get about 70 kilograms. And then this is the bit that I don't quite agree with. For a 165 centimeter female, you get a weight of 56 kilograms, which would make me look completely anorexic. But anyway, this is just the ideal body weight according to which we are going to ventilate the patient. It doesn't mean anything else to the patient. Okay. So 6 to 8 mils in the lung is lung protective. Above these levels, you are going to get barotrauma, right? So if we are going to look at, if we're going to work out how much volume we are talking about, 7 mil per 70 kilograms for an average adult male will come to about 490. Okay, so we can round that up to about 500 mils. And for an adult female, if we do the same, the volume is going to be 400 mils, right? So let's just look at that. In this example, I've set the tidal volume to 425. Good. And the machine is telling us that what is being delivered is 408, okay, which is close enough, so I'm happy with this. Let's just look at those calculations again that I was speaking about. So if we take a 70 kilogram male and we say 6 to 8 milliliters per kilogram, let's take 7, which is slap bang in the middle, then we are going to get 490, as I said. And then for a woman, so we can run it up to 500, and then for a woman, 7 moles times 56 kilograms, 390, which we can round up to 400. Okay, so I hope that makes sense to everybody. Let's go on. That we said we were going to set is the pressure. All right. Now regarding airway pressures, there are 2 things that we need to set. The peak inspiratory pressure, or the PIP, and the positive end expiratory pressure, or the PEEP. Good. Now the peak inspiratory pressure is the highest pressure that will occur in the patient's airways when you are giving a breath with a ventilator. The PIP, or the P peak, that's the other word for it, or the other abbreviation for it, should also not go above 40 centimeters water at the absolute maximum. Right. So let's just put that down there. And you can see here that our P peak, or the top alarm for our airway pressure, is 40 centimeters of water. You rarely ventilate up to that, but that's the absolute maximum that you should not exceed. Now the peak pressure is dependent on the tidal volume that you are giving the patient and on the compliance of the patient's lungs. More about the compliance a bit later. Now usually the peak pressures when you're ventilating a patient with normal lungs is around 20 centimeters of water. And you can see in this example that the peak pressure is 16 centimeters of water. Okay, so that's the PIP. Now the positive end expiratory pressure, on the other hand, is a little bit of back pressure that we apply during expiration in order to help keep the alveoli open. If we were to drop the end expiratory pressure to 0, in a paralyzed patient, the alveoli will collapse completely, and then they will have to be forced open again with the next breath. And this can cause microtrauma. It's like the alveolus sticks together and then it has to open up again, and that opening up can lead to a bit of trauma to the tissue. So it is usual practice to apply 3 to 5 centimeters water of PEEP for any patient who has a cuffed tube under the vocal cords. You can also apply PEEP if you have a laryngeal mask airway or an LMA in place, if it has a good seal. Some of the newer LMAs you can do that with as well. And on this screen you can see that I have the PEEP set to 5, right? And the feedback from the ventilator is that 5 centimeters of water of PEEP has been delivered. Good. In patients with acute respiratory distress syndrome, you can go much higher with your PEEP, but remember that it may start to influence other systems in the body. For example, your right ventricular preload will decrease and the right ventricular afterload will increase. So that's going to affect your cardiac output. Okay. You can use PEEP in patients with asthma or COPD, and it may actually help to improve ventilation because it will splint the small airways a little bit and decrease air trapping by allowing more complete exhalation. But this should obviously be done with extreme caution so as to prevent barotrauma to the lungs. So if it's something that you're not sure about, rather get somebody more experienced to help you with setting the PEEP. The fourth thing that we are going to look at is the mode of ventilation. Now there are only 2 basic modes of ventilation, volume control and pressure control. All other modes of ventilation are derived from this, so volume control and pressure control. In volume control, we set the tidal volume, and the ventilator delivers this tidal volume. How does it do it? It does it by delivering a certain flow in liters over a certain time period in minutes. So if we look at a flow versus time graph, then this is what we see. So we have on the y-axis flow in liters per minute, and on the x-axis we have time in minutes. First of all, you note that the first deflection is positive, and that is inspiration. This is the breath that the machine is forcing into the patient, so there is forward flow. But then we see that the next little thing is a negative deflection, that is expiration, which happens passively. At the beginning of expiration, the lungs are full of air and a lot of air has to leave the lungs quickly. So we see a high flow, but because it is now coming in the opposite direction, that is why the deflection is negative. And remember that expiration is completely passive. There's nothing from the ventilator that does expiration. It's purely the patient exhaling. So as the lungs become more and more empty, the flow rate becomes less because there's less air that has to leave the lungs. And then it's time for another inspiration and we see a positive deflection again. Now note that the flow in liters per minute is constant, all right? So the ventilator is going to deliver this tidal volume or flow irrespective of the airway pressures it will cause. It's just doing what we're telling it to do. So in other words, if we are going to look at a pressure versus time curve, it will be dynamic. It will change with every breath, depending on the set tidal volume and depending on the resistance in the airways. If you decrease the tidal volume, the peak inspiratory pressure will also decrease. If there is increasing resistance in the airways, then the peak pressure will increase. So the pressure versus time curve will look like this. Okay, you can see the waveform looks a bit like a shark fin. So let's think about what is happening in the lung. Initially, as the flow of gas enters the lung is empty, so there's very little resistance to flow, and the pressures are low. But quickly as the lung fills up, the resistance increases, so the pressures go up until you reach the peak pressure at the end of the positive deflection. And then with expiration, suddenly the pressure all goes down as the gas rushes in the other direction. So that's why this curve looks like a shark fin. Note that this baseline does not go down to 0, and that's probably because the ventilator is said to have some PEEP. Right. So to summarize, in volume control ventilation, we set the volume and the pressure shows the effect. Good. On the other hand, in pressure control ventilation, we are going to set the peak inspiratory pressure. So if we look at a pressure versus time graph for pressure control ventilation, then this is what we are going to see. And you can see that the pressure is now constant because we have set it. Okay, and the pressure will be whatever we have set it at. The ventilator will deliver flow into the circuit to create and to stick to this fixed pressure. So what is our flow versus time graph going to look like then? So let's bring that up. As you can see, the flow is now dynamic and changing over time. Let's think again about what is happening in the lung. We said that we are giving flow into the lung, but we want the pressure to remain steady. So we start with an initial flow, and the lung accepts it because it's empty and the resistance is low. So the flow is nice and high. But as the lung starts to fill up, there's more resistance, so the flow has to decrease. And that's exactly what we see here with that decreasing, that slanting flow rate. Good. And then the movement of air changes direction as the patient exhales, and you can see the exhalation curve looks exactly the same like it did for volume control because exhalation is passive, it's not done by the ventilator. Okay, and we can see that there is a little bit of peep set here again. And just to remind ourselves, we said that with pressure control, we set the pressure and the flow shows the effect. Okay, so it stands to reason that if we increase our pressures, we are going to increase the flow and therefore the tidal volume. And if we decrease the pressure, the tidal volume will also be decreased. So when you are setting purely pressure control ventilation, you will need to adjust the pressure until you get adequate tidal volumes, unless if you have a setting that allows you to give pressure control with volume guarantee. But I'll show you an example of this a bit later. So when do we use which mode of ventilation? For the most part, it really won't make much of a difference. Volume control is most commonly used, and most emergency unit ventilators will only allow you to do volume control. You can set a maximum airway pressure limit, but the breath itself is determined by the set tidal volume. There is some evidence that pressure control ventilation can improve ventilation perfusion matching, and obviously pressure control controls the peak pressure, so it may be of benefit in patients who you are concerned about for barotrauma. But many ventilators also have dual settings now, and this would be, for example, pressure control ventilation with volume guarantee. Okay, so let's look at a couple of examples. So here we have a nice screenshot, and this is actually showing us pressure control ventilation with volume guarantee. So note first of all that the pressure time curve is steady, right? The flow time curve is dynamic. Now in this mode, I set the tidal volume that I want, and you can see the ventilator is delivering very close to that tidal volume, but it is doing so at the lowest possible pressures. So this is pretty cool. It's the best of both worlds, and you don't need to keep on adjusting the pressures to get your desired tidal volume. One more thing to note in this pressure is that you can see that the mode of ventilation is named SIMV PCV VG. So the PCV VG we understand, it's pressure control with volume guarantee, but the SIMV that is in front of the PCV stands for synchronized, intermittent, mandatory ventilation. So what does this mean? Let's break it down. First of all, mandatory means that if you set a rate of 10 breaths per minute, the ventilator will deliver 10 breaths to the patient. So if the patient is apneic, the patient will get a minimum of 10 breaths. However, if the patient starts to breathe on his or her own, the ventilator will allow the patient to take a breath and wait with the next mandatory breath until the patient has completed their own breath. So it synchronizes the mandatory breaths to the patient's own efforts. So if the mandatory rate is set at 10 and the patient takes 4 breaths on their own, then the total respiratory rate will be 14 per minute. Okay. Now SAMV can be either volume controlled or pressure controlled, or as in this example, PCV volume guarantee. The only difference is that the machine will wait to see if the patient wants to give a breath and then just synchronize the patient's breath with the mandatory breaths. Right. Let's look at another. So in this example, we are looking at volume control ventilation. The flow in this sample doesn't appear to be as constant as in our example, which has to do with the type of ventilator in this particular machine, which gives more tapered breaths. But if you have a look at the pressure time curves, then here you can see the little shark fin shape very nicely. And there's actually an inspiratory pause here as well that shows up the plateau pressure very nicely. And I'll speak a bit more about that later. Okay. Pressure control. Now let's look at a pure pressure control ventilation graph. So note the constant inspiratory pressure again and the dynamic flow curves. Very good. So that concludes the basic settings. Now we are going to look at some of the extra or additional settings that you can also set. Okay. So the first thing we're going to look at is your FiO2, or the inspiratory fraction of oxygen. If you're working in a basic emergency room with a basic emergency ventilator, it may only be connected to oxygen, in which case you can only give oxygen, which would be an inspiratory fraction of 100%. However, if you work with a more advanced ventilator, you can titrate the FiO2 according to what the patient needs. Then you'll be giving a 50-50 oxygen and air mix, for example. So in theatre, we would usually use 50%, but it also depends on the flows that you are using. If you're using very low flow anesthesia, you will need to use a higher FiO2. To determine if your FiO2 is adequate, you can either check the end-tidal oxygen measurement on your ventilator, or you can do an arterial blood gas to look at the partial pressure of oxygen. So I would suggest starting with an FiO2 of 100% and then titrating downwards if you can. The next thing that you can set is the inspiratory to expiratory ratio. This is usually set to 1 to 2. In other words, expiration is twice as long as inspiration. And that is how we normally breathe when we are breathing spontaneously. Now you can reduce this ratio to 1 to 1. In other words, you will be increasing the inspiratory time, and you will do this if you want to improve ventilation of lung regions that fill more slowly. For example, if you have atelectasis. And also it will help to reduce peak airway pressures because the flow is now being given over a longer period of time. You can also increase the ratio to 1 to 4, for example, to allow for longer expiration. And this would be, for example, in cases like COPD or asthma, where there's air trapping and you want to allow for a longer time of expiration. So that's that, and then just a last few words about setting an inspiratory pause to check for lung compliance. To check the lung compliance, you will have to select volume control ventilation. And you are going to look at your pressure versus time curve. Remember again that in volume control, we set the tidal volume, and the pressure versus time curve will show the effect of that tidal volume on the airways in the lungs. So you will need to set an inspiratory pause, and you'll have to see on your ventilator if it allows it and then where it is possible for you to set it. And it's usually recorded as a percentage of the breathing time. Now this will allow you to see the plateau pressure, and literally what you will be doing is pausing the gas flow into and out of the patient, and the ventilator takes a measurement of the pressure at that time. So there's no air movement at the time when the measurement is being taken. And that pressure is then called the plateau pressure. Now, we're going to look at what happens with both the peak pressure and the plateau pressure and how they change depending on things that happen in the lungs or in the airways. And there are two changes that can happen. We can have either dynamic changes or static changes. So let's look first at dynamic changes. What this refers to is when there is a change in the movement of gas into the airways. Okay, so that's why it's called dynamic. It's to do with the movement of gas into the airways. So either the ET tube is blocked or kinked, or the patient has bronchospasm. So it's something to do with how easily the gas can move in and out of the lungs. Now, in this case, the peak pressure will increase, but the plateau pressure remains the same. So let's look at a graph of that. So here we have a little graph showing pressure versus time, which shows our peak pressure and our plateau pressure. And then we're going to have a dynamic compliance change. So let's say that there's a kink in the tube that is suddenly formed. And you can see here that the peak pressure has shot up, but the plateau pressure has remained the same. Now, the way that I remember that this pattern is dynamic compliance is I imagine that that this little pressure curve looks like a back to front letter D. Okay. Now, the only problem is that the modern machines don't always allow you to see the pattern because they often adjust the scale on your monitor very quickly. So it may only be for a moment that you see this particular pattern, but you may actually have to keep track of what your pressures are actually doing numerically to really see the difference. But just from a picture point of view, if you're looking at the graphs showing dynamic compliance changes, this is how I would remember it. Okay, so the next thing is looking at static compliance, and we have our little graph here again. And with static compliance changes, it means that there is a problem in the lung parenchyma. So either the patient has pneumonia or ARDS. And what we see here is that your plateau pressure has increased together with the peak pressure. Okay, so it's quite different from the dynamic changes. But again, you may not pick up on these changes in the patterns because your machine is going to adjust the scale automatically, probably. Okay, but that is just how you tell the difference between static compliance and dynamic compliance changes. And this will really be when you are struggling with too high airway pressures that you want to try and work out where the problem is coming from. Is it in the airway? Is it in your tube? Or is it actually in the lung parenchyma? Okay, so I'm going to show you just a picture of where this is demonstrated nicely. So patient in volume control mode with an inspiratory pause set up, and here we can see the plateau pressure numerically and the little inspiratory pause. Okay, good. We said that there are 5 basic things we need to remember when we are setting the ventilator: the breathing rate, the tidal volume, the airway pressure, the mode of ventilation, and then a few extra things. So that is it. I really hope that the ventilator has been explained now and that it's less intimidating. I hope you enjoyed this, and if you want to have a bit more in-depth information on this slide, Life in the Fast Lane and EM-Crit are fantastic sources if you just want to have a quick refresher as well. Okay, thank you. Bye-bye.